Hey, everybody. It's really great to be here. Dr. Jake Felice, and I am here to discuss cannabis and opiates today. You can reach me through my email, which is posted on the home slide. And there is a fair bit to talk about today, which I hope you'll find very interesting. What first got me started on this topic, this is one of the first studies that really kind of galvanized my attention in this area. In this particular study, investigators used an interrupted time series design to compare changes in level and slope of monthly opioid-related deaths in the state of Colorado, both before legalization and access for the general public and afterwards. And you can see at the exact tipping point of legalization, there was a near instantaneous change in the death statistics. The authors of the study said, quote, legalization of cannabis in Colorado was associated with short-term reductions in opioid-related deaths. As additional data becomes available, research should replicate these analyses in other states with legal and recreational cannabis. And that has, to a large degree, been done in the peer-reviewed literature, which we're going to take a look at here today. What is the terrain of pain that all of this is happening in? Over 100 million Americans suffer from chronic pain. And this affects more Americans than diabetes, heart disease, and cancer combined. Pain-related deaths, pain-related healthcare costs. Pain is expensive. $560 billion to $635 billion a year, equaling over $2,000 per year for everyone living in the United States. This comes from the Institute of Medicine report on pain in America. Quality evidence does demonstrate that cannabinoids improve short-term sleep disturbances in patients with chronic pain, which is, I think, important to note. Because as we see, and I just want to introduce here at the beginning, as we move through these studies, one of the consistent things we see with cannabis is enhanced quality of life throughout the studies. Pain is very prevalent. It affects so many of us at so many different points in time in our lives. And we don't have that many great pharmacologic tools to address the issue of chronic pain. This is the World Health Organization stepladder for pain. And most current pharmaceutical over-the-counter treatments do not provide enough relief for a large portion of the population, and they can also entail serious side effects. NSAIDs are a classic example of this, not only with gastric irritation, but trouble with liver and kidneys. And this is our terrain of pharmacologic pain therapy. Both of our big tools, NSAIDs and opiates, have very serious problems and downsides with them. Cannabis perhaps can be a good and viable concomitant alternative option for folks. Interestingly, throughout the years, increased opioid prescribing has not been accompanied by increases in other types of pain relievers. Just the opiates have been climbing up and up. And also, we have not seen the proportion of ambulatory pain patients receiving pharmacologic treatment going up either. Just the opiates prescribing has been going up. Clinical alternatives to prescription opioids, such as possibly cannabis, which hopefully I'll demonstrate to you here at least a little bit today, may be underutilized as a means of treating ambulatory non-malignant pain. As I mentioned, doctors are prescribing more and more opiates, but not other classes of pain-relieving medications. This was done by the researchers performed serial cross-sectional and multivariate regression analysis of the National Ambulatory Medical Care Survey, which is a nationally representative audit of office-based physician visits. And pain not only costs money in the healthcare system, it also on the work side, lost work-related productive time to pain in the United States costs companies additionally over $60 billion per year. Many of us have had chronic pain, and it steals our time. And it also steals money from patients, society, the workforce, with over half of the workforce surveyed reporting having headache, back pain, arthritis, musculoskeletal pain in the past 2 weeks, and over 1 in 5 of them losing productive time due to pain. So people just really do not work as well, and this has cost to business and the economy. And as I mentioned, if you have chronic pain, you know that pain is stealing time from you. This data comes from the American Productivity Audit from the Journal of Occupational and Environmental Medicine. Sadly, and I think as naturopaths, we do a great job with education, but on the physician side, the physicians in the US do not get a lot of pain training traditionally in conventional medical curricula unless you are in a pain specialty or an orthopedic practice, etc. For example, veterinarians receive 4 to 5 times the amount of education hours for pain treatment than conventional medical doctors. And large numbers of physicians and healthcare practitioners really remain unaware of the size, the breadth, and the scope of the problems of long-term use of opiates and NSAIDs that these are creating for patients. Pain is the most common reason for which people use medical cannabis. And there are now over 300 studies, including at least 36 double-blind, randomized, controlled clinical trials. Again, that's on the low side, with also at least 20 randomized parallel group trials and 10 individually randomized crossover trials showing that cannabinoids help patients with chronic pain. We need more studies, but the bulk of the literature is vast and deep, not only just with RCTs, but throughout lower level studies as well. And the general consensus is that cannabis is putatively effective for pain. National Academies of Science and Engineering and Medicine report is a great resource if you're looking to find analyses of various levels of evidence for medical cannabis. From their report, the authors, and I quote, "There is conclusive, substantial evidence that cannabis and cannabinoids are effective for the treatment of chronic pain. Results from numerous surveys indicates that cannabis is effective for pain both by itself and also as an adjunct when combined with opiates." A lot of the times I hear in media and even medical literature an either or with cannabis and opiates. Really, there is a both and. They can work very well together. And as we'll see, cannabis does not increase risk associated with opiate use. As I said before, the most common medical reason for using cannabis is chronic pain. And we do get additive analgesic effects when cannabinoids are combined with opioids. Interestingly, one of these studies is from naturopathic researchers whom I know from Bastyr University. And I would just like to say as an opening, and it's going to be a theme, a little bit of a theme of mine today, that as naturopaths, we really have a great opportunity with cannabis and especially the endocannabinoid system. The endocannabinoid system responds not only to cannabis and cannabinoids, but also our other wheelhouse of omega-3 essential fatty acids. Diet affects the endocannabinoid system. Gut flora affects positively the endocannabinoid system. Exercise, acupuncture, chiropractic type manipulations, things that we classically think of healthy are benefiting this system. I'd love to chat more about this, but we're going to focus mostly on opiates today. But just as a little ad on the endocannabinoid system and inflammation, endocannabinoid and cannabinoid receptor expressions shift within tissues in many pathological states, underlying the pro-homeostatic role of the endocannabinoid system in control of inflammation. So this is a very fluid and variable system in terms of the numbers of receptors that are expressed. And the on-demand production and metabolism of endocannabinoids does very much underscore our body's rapid response to injury or disease. This is a critically important system, and I think it plays very well to holistic and complementary therapies. Also on the other side, if we're just talking about opiates, FDA-approved opiate therapies are not risk-free, nor do they work for all patients. Alternatives are desperately needed as lives depend on them. And cannabis has an extremely low toxicity. It's estimated that the average human would have to inhale the equivalent of 2,000 to 4,000 joints in 15 minutes to kill him or herself. That's the LD50, which computes to over 100 pounds of cannabis inhaled in 15 minutes. And when they did these studies, that was really the limit that the laboratory animals could take before the carbon monoxide started to becoming a feature. So extremely low toxicity with cannabis and cannabinoid medicines. Cannabis withdrawal symptoms are typically limited to insomnia, which is common. I've written about this at NDNR so feel free to just Google my name, NDNR, and sleep. That paper should come up. One of the big problems with cannabis withdrawal is that there is a rebound insomnia. But for short-term use, I think it offers excellent options. Also, patients can have increased anxiety and sweating, which can be common. One of the most common motivations for opiate users trying cannabis is to manage opiate withdrawal. There's a real nice recent study on this showing that opiate addicts, it is now known in the opiate community that using cannabis can help overcome opioid addictions. There are very few prospective epidemiologic and clinical studies demonstrating that cannabis reduces the use of opiates, but there is a lot of data nonetheless. So yes, we need more prospective studies and clinical studies, and this is a call to research for naturopaths and naturopathic institutions. I think we have a big role to play here. And what we're going to move into next is we're going to see that there is a very deep well of correlative data. When we are talking about cannabis as a therapy, patient education is critical. And this kind of makes the literature a little bit hard to interpret. We're going to talk a bit about that today. There may be specific subpopulations of patients for whom cannabis may be most effective. And allowing for a temporary period where patients can try cannabis while weaning off of opiates is important for determining individual effectiveness for that patient's specific type of chronic pain. So why this is in our wheelhouse as naturopaths is this is a very education and interrelational activity between patients and caregivers. And it's really in our wheelhouse, and it is not so much in the wheelhouse of our conventional partners because a lot of the times their reimbursement rates for education are not good, and that tends not to happen as much as perhaps it should. And also, additionally, when we look at the laws, understanding cannabis laws really requires a lot of attention to differences in long-term versus short-term effects, as well as nuances in policies. We'll talk about this today, and patterns of consumption, as well as careful consideration of what constitutes an appropriate control group. So education, as I mentioned, is an area where we can do really well. I encourage everybody to really consider this deeply in terms of our practices and how we treat with and deal with patients. Also, cannabis has known anti-inflammatory activities that are extremely well documented. Opioids, on the other hand, have been shown to actually induce inflammation. One very important side effect of chronic opiate use is the continued engagement of pro-inflammatory immune responses that can exacerbate chronic pain. Mechanisms include effects on the inflammasome and toll-like receptors, TLR4, for example, cytokine production, and pro-inflammatory lipid signaling. Why this is important is the #1 cause of accidental death in the US is by prescription drugs. Respiratory depression is the most common cause of death for opiate patients. And it used to be back in the day that people would start with street heroin and then go pill shopping with their doctors. Now it's actually flipped, and nearly 80% of heroin users start with prescription opioids before initiating heroin. So this is becoming a large problem on the prescription side, and I think cannabis has a very good option for many of our patients. In the US, we consume 80% of the planet's opiates and 99% of the hydrocodone. Interestingly, this is investigators at University of California, Irvine, report similar findings in a policy paper for a nonpartisan think tank via the RAND Corporation and the National Bureau of Economic Research. States permitting medical marijuana dispensaries experience relative decrease in both opioid addictions and opioid overdose deaths compared to states that do not. So part of what we're seeing is not just a reduction in deaths, but also reduction in addiction rates. And this you'll see will be repeated a little bit. So it's not just that deaths appear to be going down with cannabis legalization, but addictions are going down as well. And cannabis use in conjunction with opiates does not appear to increase the risk of serious effects or death when compared to using opiates alone. I mentioned this a lot, but the breathing and cardiac centers in the brainstem do not have a lot of cannabinoid receptors in them, so we can hit the body really hard, as we saw in that previous inhalation study, the LD50, with immense amounts of cannabinoids without having toxic organ toxic effects, and also respiratory deaths. The safety profile of cannabis is clearly superior to that of opiates, as well as other drugs used to treat opioid addiction, including methadone. Respiratory risk, as I mentioned, is not associated with cannabinoids, as there are very few cannabinoid receptors located in the cardiorespiratory centers of the human brainstem. So over the years, according to CDC data, we have seen a very rapid increase in opiate-related death rates. Since 1999, the amount of prescription opioids sold in the United States has nearly quadrupled, yet there has not been an overall change in the amount of pain that Americans report, and deaths from drugs like oxycodone and hydrocodone have quadrupled since 1999. From 99 to 2016, more than 630,000 people have died from a drug overdose, with approximately 2/3 of them being from opiates. So about 400,000, which is huge. Recent data indicate that in 2015 rather, prescription opioids and heroin killed more people than any year on record. So the data is showing a constant increase in this problem that we have here in our culture. Patients often have their opioid prescriptions discontinued by physicians after dependence have developed. In a recent survey, 94% of patients report that they initiated heroin use because opioids were far more, the prescription pills were far more expensive and harder to obtain than the street heroin. This is it's a cool study. It's looking at opiate naive patients. So people who have never used opiates before. And they encounter their first time prescriptions with opiates. Opiate naive patients with 6-day prescriptions have a 12% chance being on opiates a full year later. So these patients have never had opiates before, given a 6-day prescription, and nearly 1 in 5 of them a year later are still on the opiates. If the prescription is longer, say for 2 weeks, for example, the patient's chances of being on opiates a year later doubles to nearly 24%, which is about 1 in 4 patients. This comes from data from the Morbidity and Mortality Weekly. Here is a graph from that paper. The top line is the 1-year probability of being on opiates a year later, depending upon how long the prescription is. And these are relatively short prescriptions for folks who have never used opiates before. Think about this as a business model. If you have doctors across the country initiating short-term opiate therapy for their patients who justifiably need pain control, 1 to 3 years later, large numbers of folks are still utilizing these medications. Same study, different slide. Those with a month-long prescription faced a 30% likelihood that they will still be using opiates after a year. And it's important to note that approximately 7% of all initial opiate prescriptions do exceed a 30-day supply. The synthetics are becoming more and more dangerous, fentanyl, for example. So things are changing in the opiate world in terms of death statistics. Synthetic opiates deaths increase steadily. That should be from 3,000 deaths in 2010. 6 years later to nearly 20,000 in 2016, with the sharpest increase from 2015 to 2016. This study was done and the data was analyzed from the National Vital Statistics System, multiple cause of death files. And the authors suggest that study limitations likely underestimate the number of synthetic opioid deaths, as between 15 to 20% of death certificates do not specifically, when the death certificate says death by opiates, 15 to 25% of them are not saying what type. So because of this, these numbers are likely higher. This study from the American Annals of Surgery, patients receiving prescriptions for opioids in the months before elective abdominal operations, so elective surgery, had longer hospital stays and a higher chance of needing follow-up care in the hospital or rehab center than patients who were not taking the drugs before they had the exact same operations. You know, we often pause when we're considering elective surgery with a patient based on known risk factors, whether they be smokers or have anticoagulant medications on board, and the overall medical conditions. I think this is an important piece. Same journal, different study. Opioid use is common before abdominal pelvic surgery and is independently associated with increased post-operative healthcare utilization and morbidity. Pre-op opiates represent a potentially modifiable risk factor and a new target to improve quality and value of surgical care. So what happens when we're faced with this huge problem, right? What happens when we use medical cannabis and opiates together? Good things tend to happen, at least according to the literature. Cannabinoids increase the pain relieving properties of opioids while at the same time decreasing opioid tolerance. So at the same time, there is an additive or synergistic effect to improve pain relief. There is also a decrease in the development of tolerance. So over time, patients are using less and less opiates, which could potentially correlate to fewer deaths. Additionally, cannabis also mitigates the side effects of opiate withdrawal, including reducing nausea, muscle aches, cramping, anxiety, and depression. Remember that earlier slide we talked about opiate addicts using and discussing cannabis as a means that they would use if they are needing to go through opiate withdrawal, whether they are having to go cold turkey or trying to reduce or eliminate their consumptions. So cannabis not only enhances pain relieving properties, it decreases tolerance, and it mitigates the side effects of the opiate withdrawals. But I think this is what's most important with cannabis, because again, it fits in our wheelhouse as naturopaths, quality of life. Despite its widespread use, with more and more being prescribed every year, there is very poor evidence for long-term effectiveness of opioid therapy. And perhaps one of the reasons from that earlier slide is that potential for chronic opiate use to increase the inflammatory immune response. So very importantly, opiate therapies do not enhance quality of life. And also very importantly, if you look throughout the cannabis literature, so many studies, guys. The vast majority of cannabis studies examining quality of life show an improvement in quality of life. One example, cannabinoids improve short-term sleep disturbances for folks with chronic pain. That's the reference here to the lower right if you want to read this study. So I think very encouraging to compare and contrast the cannabis and the opiates. But as I mentioned, positive and additive interactions exist with cannabis and opiates. And I think that botanicals are an area where we, as naturopaths, we understand pharmacognosy, and we can really thrive and contribute to the forward progress of science. And I encourage folks involved in our various naturopathic colleges and universities, research institutions, to start thinking about cannabis, because as I said, it's really in our wheelhouse. Medical cannabis, when combined with opiates, helps patients obtain better relief and helps patients for whom opiates have been ineffective due to tolerance. So I mentioned in the prior study a reduction of the development of tolerance, but this particular study is discussing once tolerance has already developed to opiates. Tolerance has already developed to opiates, a reversal of that. And as I mentioned, again, good to reiterate, cannabinoids also can prevent the development of opioid tolerance. Medical cannabis patients using opiates report a reduction in opiate doses, a reduction in opiate-related adverse side effects, as well as what else? Sorry, I'm so passionate about this, but again, from this study, increased quality of life. So the cannabis is affecting opiates on multiple levels. How does this affect when we start to change the legal environment in and around which cannabis is utilized? I think we start to see profound changes. In these particular studies, implementation of effective medical cannabis laws led to a reduction of over 1,800 daily doses of opioids per physician per year. And the reduction in prescribing patterns was substantially corroborated by the same authors in a different study. Both of the references are here, using Medicaid data from 2007 to 2014. Additionally, Medicare data shows that once states institute medical cannabis laws, prescription drug use across the board starts to fall significantly. Again, if you're looking at this from an economic perspective, I think big pharmaceutical companies do have a lot of skin in the game when a new product comes to market that is not patentable, namely a botanical called Cannabis, and their revenues start dropping. Another study shows that in states with legal cannabis access, 13% fewer abuse-related hospitalizations and 23% fewer opiate-related deaths. So it's not just fewer deaths, fewer addictions, fewer patients, less drug use, fewer hospitalizations for abuse, and fewer overdose-related hospitalizations. In these studies, linear time series regression was used to assess these associations of implementing medical cannabis policies to hospitals and controlling for other marijuana and opiate-related policies, socioeconomic factors, which are important, and also the state and the year in which it was looked at, because the laws have changed rapidly over the past decade or so. The broader the legalization policies, the greater the rates of decline. So in some states, Washington, Oregon, California, you have both recreational and medical laws. You have lots of brick and mortar dispensaries where patients and general public can go to have safe access. These are associated with greater rates of decline. In one study using Medicaid prescription data from 2011 to 2016, medical marijuana laws and adult use marijuana laws were associated with lower opioid prescribing rates. This was done by investigators from University of Kentucky and Emory University, and they looked at these relationships. Researchers reported the enactment of both medicalization and adult use laws were both associated with reductions in opiate prescribing rates, with broader legalization policies associated with the greatest rates of decline. So not all laws in all states are created equally. Some states, for example, you may be legally able to possess cannabis, but you can't buy it legally anywhere. So that's not an example of a law that is not as good. I believe Arizona is currently sitting in that status. Hey, I could be wrong on the laws. They're changing so fast these days, it's hard to keep track. Different study, researchers examining a huge data set of 1.5 billion individual opioid prescriptions found that medical and recreational cannabis access laws reduce the number of morphine milligram equivalents. These new laws also decrease the total day supplies of opioid prescription, the probability of a provider prescribes opiates. So not only do the laws reduce the total supply being used, but the number of prescribers goes down, as well as the number of patients receiving the medications goes down. The authors state, quote, additionally, we find consistent evidence that cannabis access laws have different effects across different types of providers, physicians, and insurance payers. So not all physicians are being affected equally. My personal hypothesis is that this could have to do with physician education, which is why I'm so happy to be presenting to naturopaths. I think we can really be leaders in this area. Additionally, all these new synthetic analogs, fentanyl, may also be obscuring some of the data from positive effects of medical cannabis against opiate harms because the fentanyl is so powerfully addictive. The effects of cannabis policies on opiate-related hospitalizations and emergency department visits vary depending on the type of cannabis laws in effect. Different study, same basic conclusion. States without medical cannabis laws have lower OD reporting standards, also compounding the difficulty. So states that are, they're backwards with their cannabis laws. Sorry, I said it. I can't take that back. But they're also tend not to have as good a quality of reporting systems. So that makes studying this a little bit challenging sometimes. In this slide, researchers report that medicalization and specifically the establishment of brick and mortar cannabis dispensary facilities correlates significantly with reduced prescription drug use. So by brick and mortar, what I mean is a cannabis shop that a person, an adult, can walk in and legally purchase cannabis products, as opposed to just a law that allows someone to possess it without having fear of going to jail. So the actual presence of brick and mortar correlates significantly with reduced prescription use. In this study, University of Georgia researchers evaluated the association between the enactment of medical cannabis access laws and opioid prescribing trends among folks eligible for Medicare Part D prescription drug coverage. So we have a lot of ability to correlate and control this data. Researchers report that medicalization, and specifically these stores opening, is a big feature. And the authors speculate that a savings of over $1 billion could have been realized in 2014 if all states had medical marijuana access laws. And it should just really come as it came as a surprise to me that the medical piece, I think the argument is really good, but the monetary arguments in favor of cannabis legalization, I think, are also powerful. Different study, still utilizing Medicare Part D data, this on orthopedic surgeons. And they looked at annual aggregate daily opioid prescribing per orthopedist. They used linear regression models and then compared the association between state medical cannabis laws and opiate prescriptions. Very interestingly, in this study, no significant association between recreational laws and prescribing was found, but there was a statistical difference between medically oriented dispensaries. I don't know what this could it be that that added education in medical dispensaries has an effect so that the patients going into a medical dispensary are receiving a better quality education? That's a hypothesis, would need to be tested, or perhaps social factors that differentiate medical and recreational laws in the public mind. So sometimes it's not great to look just at state laws. You can get a little more granular when you look at county laws. This particular study of county level counts and opioid deaths, higher numbers of both recreational and brick and mortar stores are associated with reduced opiate deaths. So not necessarily the same result from the last study, but this is at the county level. These associations are also more particularly associated with fentanyl-associated overdose deaths. So all of these new synthetics coming up from Mexico, from China, make this studying of this a little more challenging. But I think it's something to think about when states are trying to enact or ration the number of cannabis licenses for storefronts, such as what they do in Washington state. What this is showing is that allowing more small businesses to thrive, allowing a greater number of dispensaries can have a positive impact on the patient, or rather the general population. I really like this study because I do think of myself as an educator. Reduction in opioid mortality generally strengthens after the passage of medical cannabis laws. So we have the enactment of a new law, such as that early slide in Colorado that I showed you at the beginning, where we see a increase in opiate deaths, legalization, the trend starts downward. As time moves forward, the correlation strengthens. So one of my hypotheses is that over time, the improvement might be a feature of consumer awareness, consumer acceptance, physician awareness, and physician acceptance. Bottom line is that when medical cannabis is initiated, the patients use less of multiple classes of medications. These are naturopathic researchers published in a major journal, the Journal of Pain Research, all of them naturopaths. A total of over 1,200 respondents reported a total of 2,400 plus substitutions. So for each patient using medical cannabis, we're averaging 2 drug substitutions per affirmative respondent. So patients weren't just reducing one type of medication when they started using medical cannabis, they were reducing multiple types. The most common classes were narcotics, opioids, anxiolytics, benzodiazepines. Substituting cannabis for narcotics and opioids was 2.6 times more frequent than substituting cannabis for anxiolytics or benzodiazepines, the second most commonly substituted category. A recent study of opiate patients shows that over 2/3 use cannabis to reduce prescription drugs. And another survey indicates that about half. So this particular study is just not a one-off there. It has been replicated at least a couple of times. In one survey, over half used cannabis, a different survey, over half used cannabis to replace prescription drugs. And again, pain meds, and in this case, antidepressants and arthritis drugs were the most common drugs to be replaced by cannabis. In this study, nearly 2/3 of the patients used CBD-based cannabis with less than 0.3% THC. So so these patients are not getting a head high. They're not having a major psychoactive psychedelic effect. Nearly 2/3 found cannabis more effective than their prescribed drugs, and over 4/5 noted that the side effects of their prescription drugs were, all caps, much worse than medical cannabis. This comes from the Harm Reduction Journal 2021 study. Research demonstrates that the use of medical cannabis patients also reduce not just their use of prescription drugs, but more harmful substances, including alcohol, illegal opiates, and cocaine. So it's not just fewer prescription drugs, but less alcohol, less cocaine, less heroin. In this observational analysis of cannabis substitutions among medical cannabis users with chronic pain, results were looked at an ongoing online survey of medical cannabis users with chronic pain nationwide about how cannabis affects and how they use cannabis in their pain management and for their healthcare. And again, in this study, results confirm previous clinical studies suggesting that cannabis is an effective analgesic and a potential opioid substitutes. Participants reported improved pain, better health, and fewer side effects as a reason for their substitution. For folks who are currently using illegal drugs, a negative association between chronic pain, people using illegal drugs and concomitantly have chronic pain, plus cannabis. In this study, data from 2 prospective cohorts for these folks observed an independent negative association between cannabis use and illegal opioid use. So I use the word heroin. I know there are other types, fentanyl, off black market fentanyl, et cetera. But for folks who are using the opiates illegally, their rates are also going down. Authors state, quote, "These findings provide longitudinal observational evidence that cannabis may serve as an adjunct or substitute for illicit opioid use among people who use drugs with chronic pain." This study looks at the Clinical Opiate Withdrawal Scale, COWS. Medical cannabis provides relief from opiate withdrawal symptoms based on the Clinical Opiate Withdrawal Scale, a guide clinicians use to judge the stage and severity of opiate withdrawal in a patient. So cannabis appears to be helping not only on the pain side, but also on the withdrawal side. And this, as we have seen, has already been corroborated by several other studies. I think these numbers are notable. the most common prescription medical in this particular study replaced by medical cannabis were opiates. And it was a pretty large percentage, with up to 72% of patients in the chronic pain as their primary illness group reducing their opiates. This is notable given the well-described opioid sparing effect of cannabinoids and the growing abundance, and these are quotes from the author, and the growing abundance of literature suggesting that cannabis may help in weaning from these medications and perhaps providing a means of combating the opioid epidemic. Here's a study of cannabis for chronic pain in older adults, different population. Researchers used a logistic multinomial regression model and looked at factors associated with opiate use in cannabis. And this is where the research can get a little sticky. And I mentioned this in the beginning, contextual factors, because remember, these are our seniors, our older folks. Contextual factors such as sex, finances, very importantly, physician attitudes and personal beliefs can influence a patient's choice between opioids or cannabis. And again, this is the study, opioids or cannabis, but remember, they can be used together. These contextual factors may be more influential than individual needs, including pain and quality of life. So people are making these decisions based on not necessarily rational reasons. And again, it goes back to that one slide where we showed that over time, the correlation between medical cannabis laws as it matures, we see an increase and an improvement over time of opioid-related deaths. So again, this further emphasizes the need for physician education in this very important area. Here we have and this study looked at beta-caryophyllene, which is a sesquiterpene common in plants, lands on the CB2 receptor. Retrospective mirror image study investigating cannabis effectiveness from chronic pain associated with qualifying conditions for medical cannabis in New York State. After 3 months of treatment, medical cannabis improved quality of life. Again, here, quality of life improved, reduced pain and opioid use, and led to cost savings. So it's also, there is an economic argument here. These results are consistent with previous reports demonstrating medical cannabis effectiveness in neuropathic pain. I find that beta-caryophyllene and neuropathic pain with cannabis works great together. Beta-caryophyllene is present in a lot of cannabis products. As I mentioned, it's a common sesquiterpene found in a lot of plants, cloves, cayenne pepper, copaiba oil. It's just, but you can do an additional beta-caryophyllene supplement along with a CBD product to get enhanced effectiveness on neuropathic pain. Clinical pro. Aim of this particular study was to characterize the epidemiology of cancer patients receiving cannabis treatments and defined the safety and efficacy of this therapy. In this study, nearly 50% of folks are reducing their analgesics and other sedatives. Opioids, for example, was the most common drug consumed by patients at intake, and 36% of the cancer patients had stopped taking opiates, and about 10% had decreased their dose. So put that in the context of end-of-life care, where you're with families are with a loved one and the opiates make them sleepy or groggy or just not there. Keeping folks in their body aware as opposed to still alive but knocked out, I think is hugely important for quality of life. Another great study. Preclinical animal models are showing that the cannabinoid CBD reduces reward-seeking properties of opiates and decreases heroin-seeking behaviors. So it's not just THC-based cannabis that's important. I'm going to rush because we're near the end here. In this particular small pilot study of opioid-addicted humans, a single dose of CBD produced a decrease in opiate cravings after 24 hours. with the effects lasting for 7 days. That amazes me. I'd love to see somebody try to replicate that. Anxiety levels in patients were also reduced at this time. 1 dose of CBD reduced cravings and anxiety for 7 days. That's kind of astounding. I'll be curious if that can be replicated. Also, when you're dealing with addiction and recovery programs, cannabis users are more likely to stay on track in their programs. Authors of this study from the New York State Psychiatric Institute assessed treatment retention rates among opiate-dependent subjects in a 6-month outpatient program. They report that the addicts who were using cannabis intermittently were significantly less likely to reinitiate opiate therapy during the treatment program as compared to those who used it all the time or not at all. So here is a call to moderation. Patients using cannabis during the program were also more likely to adhere to naltrexone treatment. The authors concluded that occasional cannabis use, quote, may support a harm reduction approach to naltrexone maintenance. European Journal of Clinical Medicine, a prospective study, looked at patients above the age of 65 years, so another study in older adults, in a specialized medical cannabis patients. The authors conclude our study finds that the therapeutic use of cannabis is safe and effective in the elderly population. Cannabis use may decrease the use of other prescription medications, including opiates, and again, increase quality of life in this study. This study on this next slide from the Journal of Neuropsychopharmacology, although active cannabis and 2.5 milligrams of oxycodone alone failed to initiate analgesia, so they gave a little bit of cannabis, no relief. They gave a tiny amount of opiates, no relief. But when you combine them, they increase the pain threshold and tolerance. Inhaled cannabis combined with an ineffective analgesic dose of oxycodone produced pain relief comparable to an effective opioid analgesic dose, but without significantly increasing the cannabis abuse liability. So again, this looks and appears to be an additive or synergistic effect with botanicals, guys. This is our wheelhouse. Botanical synergy and entourage is our wheelhouse. Let's study and publish on this more. Another study with synergy or additive effects, 21 individuals with chronic pain on a regimen of twice daily dose of morphine or oxycodone were enrolled in the study. Authors conclude, quote, vaporized cannabis augments the analgesic effect of opioids without significantly altering opioid plasma levels. So it's not affecting clearance, or it doesn't appear to be. This combination may allow for opioid treatment at lower doses with fewer side effects. 2016 open label trial from the Journal of Clinical Journal of Pain reports that patients with treatment-resistant chronic pain report improvements in pain. What else? Pain-related quality of life. Surprise, but here it is again, quality of life with cannabinoids. 44% in this study were able to discontinue opiates entirely. I love this study. The authors concluded, quote, in blue, opioid use is not correlated with better health, with better health-related quality of life. Opioid use, okay. I looked at over 5,000 patients. It's a retrospective cohort study. And opioids are not, a different study here, but opioids are not associated with health-related quality of life. So this particular study in 2016, prescription opioids were eclipsed by synthetics such as fentanyl as the most common drug class involved in opioid-related overdose deaths. And again, as I think we look into the opiate literature in current and future studies, this fentanyl or these synthetics are going to make it a little bit harder. clinicians, first responders, and lay persons likely to respond to an overdose should be educated regarding synthetic opioid risks and provided with multiple doses of naloxone. So this is a good study to be aware of, and I'm sorry I can't see from the slide which journal this is in, but the authors state the opposite of what a lot of these prior studies have been showing. The authors state that cannabis use appears to increase rather than decrease the risk of developing non-medical prescription opioid use and opioid use disorder. So what's going on here? These authors found a completely opposite result. Think about it. Look at the slide. Okay, now, here's my thoughts. Look at the where and when was the cannabis sourced. Wave 1, 2001, 2002, and wave 2 is in 04 and 05. What was the legal landscape at that time? The legal landscape at that time was black market sourcing. So again, we have a potential for a change in laws affecting the way these drugs behave, not necessarily physiologically, but societally. The same guy on the street corner selling crack cocaine or the other drugs that I don't even know the names of, will also, if somebody's just looking for a little weed, they might have some other products that might be free for them to try for a little bit. So the sourcing of black market cannabis does represent a risk factor for future opiate use. But when we change the legal landscape, it appears that a lot of that is completely cleared. In this study, levels of depression and anxiety are higher among chronic pain patients receiving prescription opioids compared to those receiving medical cannabis. This was a cross-sectional study, and depression and anxiety were assessed using the depression module of the patient health questionnaire and the generalized anxiety disorder scale, number 7. All right, this is my last slide. From the Journal of Pain Medicine. I love this study. It's what really got me passionate about cannabis, not this study, but I corroborate, my clinical experience corroborates this study. Restored Self, a phenomenologic study of pain relief by cannabis. And the journal, the authors discuss that pain relief by cannabis can be described as a sense of restored self. So my patients would come back and say, I feel like myself again. People in chronic pain can lose that sense of self. I've got my mojo back. I've got my shine. Authors proposed, quote, the term restored self to conceptualize the effect of medical cannabis. Restored self is the experience of regaining one's sense of self, sense of normalcy, and sense of control over our lives. And again, this points to the quality of life benefits that are potential from this very misunderstood botanical. I would like to close in saying that I do think that certain institutions in naturopathic institutions, my opinion just on feedback, I'm not associated with any of these now, is that some of these are really hesitant to talk about, teach, and promote medical cannabis as a therapy for naturopaths because they don't, let's face it, they don't want us to appear kooky talking about weed. What are we, weed doctors? Are you just marijuana doctors? But I think that from some of this data, just this small sampling of data here, combined with a lot of other research and writings that not only I have done, but that are also being presented in this conference, we can see that as naturopaths, there is a wonderful role as a complementary and alternative therapy. Cannabis is not a perfect medication, but it does give us many tools to address a lot of problems for opiates and the opiate overdose epidemic that we're having. I'm Dr. Jake Felice. You can find a lot of my work on YouTube. At NDNR, I write a regular column. You can contact me through my email, which is you can see here. And I really enjoyed the opportunity to present this topic, of which I share a large amount of passion because I see cannabis changing lives for the better. And I really thank you for listening. Cheers.